All right. Great. Thanks very much, Alan, for that introduction. I'm not playing hooky. I did leave the ICU earlier a few days ago, and since my office has no heat, I'm actually at home. Um, uh, so thanks for the introduction and also the invitation to speak with you folks today. And you're welcome to interrupt in the middle if you have any questions. It won't be an interruption. I'll give a brief case and then talk about have a couple questions per Alan's request. So just somebody, Alan, give me a thumbs up. Can you see the screen on slideshow? Okay, great. So thanks very much, everybody. Welcome. I've got the date wrong here. Sorry about that. So I'm going to start with a case presentation. This is somebody who I actually did see in clinic. Because of the nature of the disorder, it ended up being something it's an older case, but still is very relevant for general knowledge about work-related asthma syndromes, as well as certainly some things that will likely come up, on the boards. I know we're trying to, mix a combination of didactics that will prepare you for things that you don't see so frequently, but may come up on the exam, and also just talk about general syndromes overall, which you may or may not see. Some of these cases are a bit less likely to be seen, although there is one of my review questions does involve the crossover between kids and adults. So this is a 45-year-old gentleman who had about 20 years of mild intermittent dyspnea and cough. He used an inhaler in childhood for about a year, but he thought that was probably overkill. A competitive athlete in high school and college, and then went to college and law school, actually, in the Boston area. And he had a clerking job at the Suffolk Superior Courthouse, and noted onset of symptoms about 3 months into working as a law clerk in downtown Boston in 1993. He had a hard time walking upstairs. His chest felt tight, and they were somewhat reminiscent of some of the symptoms he had when he was a kid. He also had some headaches, but remained active otherwise. He did see a pulmonary doc at New England Medical Center, which is now Tufts Medical Center, but I didn't have any access to any records. And he came to me because he was preparing to do a sort of very high intensity race called a Spartan race that included certainly a fair amount of exertion and respiratory demand, and wanted to just sort of know how this episode might have impacted and what we should be thinking about, this now being several years after he'd had these initial symptoms. So he gives a history of walking pneumonia, that's his term, in 2009, and then was noticing around the time I saw him just a little bit more prolonged cough, intermittent dyspnea, and chest tightness when he was training for this event. The initial symptoms had been persistent from when he had this problem in 1993, but they had overall improved. But he said sometimes he can't take a full breath. So past history, is a pretty healthy person. He had no symptoms of allergic rhinitis or other known air allergen sensitizations. He has sort of the injured jock syndrome, where he's had an ankle repair and an ACL repair. Interestingly, had cataracts and a retinal detachment, which are not related to the current case, but were an interesting sidebar. He works in class action law, including medical malpractice. From an allergy standpoint, he was born in New Jersey, but moved very early on to Colorado at age 3, where he went to high school and college before coming back to law school in 1991. No inhalants, either illicit or licit. He has a nice house with area rugs. Kids are healthy. Not taking any medicines, rare NSAID use, and has no side effects from that, and has no known drug or food allergies. So with this in context, so I'll just go back here. So gentleman who had sort of a bronchospastic syndrome that was quite significant a while ago, that's gotten better, but recently with some recurrence of symptoms. So anybody have, I don't know how interactive this will be. I'm happy just to sort of go through it, but does anybody have any thoughts about initial evaluation that I might want to do on this gentleman? Nope. Okay. So I'll tell you what I did. Anybody who, I think that in the adult space, most people who have an atypical or even typical asthma syndrome, I think nobody would be faulted for getting a chest X-ray, similar to what we see in people that have chronic cough. And this was his chest X-ray in November of 2014. And I'm not sure how many of these will come up on the boards, but you'll see clear vascular markings here. All of the important borders are visible: left heart border, right heart border, the right hemidiaphragm, which is cut off a little bit here, and a little bit on the left, but we can see in the lateral two nice hemidiaphragms with no evidence of a spine sign, no enlarged, sort of a normal retrosternal airspace, and no evidence of any kind of a pleural effusion, just to kind of be comprehensive. And the bones look fine. So I decided to start by just getting pre and post bronchodilator spirometry, and I won't ask people to interpret this, but I will point out some of the key factors. One is I always start looking at the flow volume loop, and this is flow here over volume, and you can see this nice sort of triangular rate with a very rapid onset to peak expiratory flow, and then this sort of envelope that should be relatively flat, which incidentally you can't go past this sort of physiologic envelope of the flow rates that you can achieve as you are exhaling and your lung volumes are smaller. So even if somebody were to cough, you would see the rates go up and then down, like, and then as the person were to cough again and breathe out, you would not pass this sort of this barrier or envelope. Interesting factoid about sort of flow rates during different levels of lung emptying, and how there are limitations to that. This was not a proper inspiratory flow loop, so I'm not trying to show you a case here of a variable obstruction here. This is just a relaxed inspiratory effort. And you'll see, even including the new guidelines for interpreting reversibility in spirometry, that there was really no change. But he did mention that it was so good that the respiratory therapist wasn't sure if the post was necessary, but I sort of insisted on it. It was done a little bit sooner after albuterol than I would have liked, but certainly there was no major improvement, except for maybe in the mid-expiratory flow rates, but those we are not looking at these days, just given the wide variability of being able to interpret that, including the Z-scores. So I tend to look at it as a hint, because I like to give patients the benefit of treatment if there is even a hint of reversibility, but really not much in this case, and certainly not in the FE1 or FEC. So what further information would help us understand what happened back in 1993 and what might be going on now? Any thoughts? So it's probably a bit too big of a group to be interactive, but I will probably call on people when we do the review questions in the end. So the question here, the main information we want to know is what was going on in the Superior County Courthouse when he had these new onset symptoms, and somebody who is basically a high-performance athlete, although not Division I. What was going on around then? He wasn't the only one that had some of these symptoms. And it seemed like this was a new onset, situationally or location related sort of bronchoconstriction and respiratory syndrome that came on several months after starting in a new workplace, and after leaving that workplace, ended up having persistent symptoms, which over time gradually improved. And so we want to know whether this is, occupational asthma, work exacerbated asthma in somebody who is coming into a new circumstance, but with prior sensitizations, or what else was going on during that time, and maybe the exposure and timing of workplace presence was not related to his development of symptoms at the time. So that would be the information that we would want. So this is sort of a kind of an algorithm, if you will, for looking at whether somebody has. It's a sort of a chart that will flow down just to kind of give an idea about consideration of the diagnosis of work-related asthma writ large, and then some of the subcategories that are in them. So the first thing to do, as you can see here, is really confirm asthma as a diagnosis and its onset, looking at the medical history, symptoms. These are things that you're all relatively familiar with. Spirometry, whether there's reversibility or not, and in cases where the diagnosis of asthma is unclear, doing testing to a non-specific bronchoprovocator like methacholine, histamine has been used, and some other substances. And I say a non-specific bronchoprovocator because as in contradistinction to a specific bronchoprovocator, which might be somebody who is allergic to a certain air allergen, and you would see whether they're sensitized and whether there's bronchoconstriction related to exposure to that specific air allergen, mostly done in a research setting, but not exclusively. An example might be somebody who might have exercise-induced bronchospasm or consideration of that, in which you would have them exercise and do serial spirometry to see if there is a drop in FEV1 with greater exercise. So methacholine is a non-specific bronchoprovocator. It distinguishes people that have airway hyperreactivity from those that don't. And the point here is that everybody, all of us on this call, have a PC20 to methacholine, a concentration of methacholine that will lead to a 20% drop in FEV1. For most clinical asthma studies, that cutoff is 8 mg per mil. Mine is probably around 1 or 0.5 because I've had asthma my whole life, and I was involved in research studies as a volunteer where I actually had a methacholine challenge. But everybody has one. It could be 80, it could be 160 mg per mil, but we usually in clinical work go up to 25 mg per mil. And if somebody doesn't have a 20% drop to a non-specific bronchoprovocator, we say that they don't have airway hyperreactivity. So I think it's important to understand what methacholine does and that it has an impact on everybody, but it does distinguish quite well people who have airway hyperreactivity, where their drop in FEV1 will be usually well below 8 mg per mil, and sometimes even down to 1 or less than 1. So very, very sensitive. So once you've done that, you have to figure out if you have asthma or not, and then you would explore the different exposures. I'm not going to go through these in great detail. If this workup shows that they don't have asthma, then you have to look for other causes, some of which, as noted here, can coexist with asthma. And then the question is whether the symptoms of asthma are related to work. And there's things that we learn about if people are away from work for a longer period of time, like vacation. Do they end up feeling better? What's the nature of onset of the symptoms? Did it happen immediately when they started a new work or working in a new building or a new setting? Did it take 3 or 4 months or some time before they started to have symptoms? And then there's the concept of sort of people who are working 5 days a week, whether they feel better kind of on Sunday and then Monday or Tuesday start to feel worse. So those are kind of the paradigmatic signs that asthma seems to be associated with work or a setting, like a building, for example. But sometimes people's work schedules, particularly in our patient population, are quite erratic, and we don't have the benefit of having a time away from work that's long enough to know whether symptoms are better or not. So amongst work-related asthma, then you decide if it's a primary occupational asthma. In other words, is this something that is completely new for the individual? And if the answer is yes, then it's so-called occupational asthma or new onset work-related asthma. Or is this something that is work-exacerbated asthma? So this would be where somebody has already been sensitized to an agent, typically an air allergen of type, and whether they had this before and they're going back into an environment that is known to have triggered them in the past, and that'll be relevant as we move on. Or if they really haven't had asthma before, but they're developing an asthmatic syndrome in a new workplace, right? So in terms of the work-exacerbated asthma would be really trying to minimize exposure and identifying the exposure that somebody had previously been sensitized to and has asthma related to it, and trying to sort of minimize that. I won't get into the legal issues of this, but that is embedded here in some of these boxes. And then I'll go into more detail with the management of occupational asthma. This is from sensitizers, irritants, or sometimes both. And the management here is typically diagnosing what it is that is causing the occupational asthma, which I'll go into a bit more detail on, and then trying to minimize that exposure. So before I go into sort of the specific causes, I wanted to give a little bit of epidemiology. So it's the most prevalent occupational lung disease, much more common than sort of pneumoconiosis, which we see in the adult pulmonary world, co-workers pneumoconiosis, silicosis, et cetera, things that you won't come into too much in your clinical practice for sure, and probably not on the boards. It's likely under-recognized in the clinical setting, and it accounts for almost a fifth of adult onset asthma cases that we see. It depends a lot on varied clinics. Some clinics will have more concentrated, representation of people that have work-related asthma, and some not so much. In our patient population, we see a lot of asthmatics that are related to their home environment as much as the environment in which they work. So the median prevalence amongst adults is about 22%. So this is more incident cases here, and these are people that have had it and continue to have it because they can't necessarily avoid where they're working. So we see a lot of patients, for example, who work going into other people's houses to clean, to do work, and there may be triggers that are there, and they can't really avoid them because they need to continue their employment, whether they're allergic to pets or pests or other things that are in that work environment. And I quote some studies suggested that it's much higher than that in terms of prevalence. And the burden on quality of life is not trivial, as noticed in the next bullet. No specific gender ratios, but they're for reasons that probably have to do with choice of employment, need to work, and other social determinants of health. Workers who are Black American, American Indian, or Alaska Native, multi-race, or particularly Puerto Ricans have a high prevalence of work-related asthma. And as you probably know, people who are Puerto Rican have, U.S.-wide, have a significantly high, about 3 times higher prevalence of asthma than the general population. So in the United States, it's at around 9.5% or so, and amongst people of Puerto Rican ethnicity, it's as high as 15 to 20%. So just something to know about that, and that also will probably steer a little bit the prevalence of work-related asthma amongst those populations. So this is sort of my 30,000-foot view of the way to think about work-related or occupational asthma or airflow obstruction into 2 sort of main buckets that have some defining characteristics. So those who have no latency, which means that people can have symptoms soon after starting that occupation or being in a certain physical setting, and those that have latency, which you can think of as sensitization with a few small exceptions, which I'll point out and are important to know. So those with no latency, it's usually more related to the intensity of exposure. Irritants and small molecules or particulates can be significant contributors. So, for example, people who were World Trade Center first responders, probably due to particulates and small molecules, those symptoms can persist after removing that. So the 1984 Bhopal gas disaster was methylene methyl isocyanate gas. And I put an asterisk here because compared to other, not to be confused with other isocyanates, which are usually diisocyanates, methyl isocyanate is an irritant and is known to not be an occupational asthma sensitizer. So this is really kind of a chemical exposure that can lead to a bronchoconstrictive syndrome. Similar to a lot of our patients, there's a lot of huge Brazilian population that we see here. A lot of them work cleaning houses, and they can't necessarily choose, what they're exposed to if they're going to be cleaning, both in terms of the environment that they're there or the cleaning products that they have. And many have an irritant asthma syndrome that's related to cleaning products. And the more they're exposed to them, the more symptoms they will have. So this has to do, once again, with the intensity of exposure. And then there's a very distinct syndrome that may come up on the boards, and it's a distinct entity called RADS, or reactive airway dysfunction syndrome. This is one where there's no latency, and it's usually a one-time high-level exposure. And it's a short exposure, typically because it's very noxious. It's not a hidden exposure. So somebody who is exposed to a lot of smoke, for example, and they just couldn't get away, whether they're working as an occupation or whether they just got a huge whiff of of burning brush, for example, or other certain toxic chemicals. So these are some of the examples. In World War I, some of the horrible gases that were used did lead to reactive airway dysfunction syndrome. And what's important to know about this, and I'll get to your question in a second, is that after you're removed from that, there are structural and physiologic airway changes where airway hyperreactivity done by methacholine and symptoms can persist well over 12 months. And some people never completely recover, and it probably has to do with the level of exposure. So Elsa, go ahead. You had a question?
Yes, thank you. I had a question, and maybe this is like the wrong time to ask, but I was wondering about the role of masks in helping some of these patients who can't be removed from their work environment. And then I was also wondering if if employers have a responsibility to address this. I don't know if there's any legal things or anything we can do as a doctor in terms of supporting these patients.
Yeah. So to your first question, it depends on whether it's small particulates, especially with a N95 mask, or whether it's something that's like a volatile organic compound. So if somebody is exposed to small particulates as irritants that an N95 mask will block out, then that would be helpful, assuming it's well-fitting. Anything that's aerosolized or very small, but still a particulate matter. If it's sort of a volatile organic compound, then that really goes by diffusion and probably will still be breathed in. I think in general, people do get benefit from wearing, a high quality mask, not a KN95, but a true medical N95 mask. And sometimes we have some around in our clinic, and I'll give them to the patients because if you buy them on the open market, they can be quite pricey, at least for our patient population. And the answer is yes, there are all kinds of rules and regulations about how employers should accommodate individuals who, with a medical evaluation that says, yes, this is a work-related asthma syndrome, they should be responsive. But then there's a range of employers, and amongst our patient population at Boston Medical Center, I think that the concern about making a fuss is a bigger factor as a social determinant of health. And so many times, the regulations are there and there should be accommodations. Certainly people are working for larger companies, but then people are working for smaller businesses or are working on their own account, like cleaning houses where they're technically self-employed. Then it becomes more to your first question about trying to help them mitigate as much as possible their level of exposure.
Perfect. Thank you so much.
Yep. So then the second sort of bucket here is with latency or sensitization, and I put another sort of double asterisk here is key to differentiate new onset or primary occupational asthma versus exacerbation of pre-existing asthma with known sensitization, and that's so-called work exacerbated asthma. So somebody may have symptoms soon after going in a new, in what's a new job to them, but it may be that what they're responding to, if they have symptoms right on soon after starting, is that it's work exacerbated asthma, in that they know they're already sensitized to something, but they don't have a latency period. So it's key to kind of differentiate those. So most of them that have latency, and are really large molecules. So high molecular weight molecules typically are protein allergens. So flour, and the list is very, very long, and I'll show you an example of that list. But there are a few small molecules that have IgE and some non-IgE mediated mechanisms that are not super well understood for what explains the latency for these small molecules. So the sort of the paradigm for that are isocyanates, as I mentioned, where there is a latency even though it's a small molecule. And then I put in bold here plicatic acid. This is a product of Western red cedar milling and carpentry work that is a sensitizer, but a small molecule. It's something that very likely could come up as a question on the boards if somebody is a carpenter or working with Western red cedar in particular, where they develop an asthma syndrome that has latency but is a small molecule. And the mechanism is possible haptenization with intrinsic proteins, and know that airway hyperreactivity can persist after removal from exposure. And I'm quoting here a longitudinal study of Western red cedar workers with occupational asthma who were taken away but had persistent symptoms in airway hyperactivity despite being moved away, which is kind of in contradistinction to somebody who has asthma that's irritant because of bleach or other strong cleaning products. Usually after they're away the next day, they feel pretty well. And the majority of those with sensitization, in fact, are these large molecules. So this is a large, sort of a long chart that sort of gives example of sensitizers that are reported to cause occupational asthma in the associated industry. Since this is being recorded, I'll leave this sort of as kind of like a repository, if you will, but I would become familiar with some of these. So there's the high molecular weight and the low molecular weight. So the high molecular weight, often animal or insect derived, so bird proteins, people who work in hen houses, people who work in laboratories. Mouse urine is a major source of mouse allergy, certain bacteria and fungal derived, and then plant derived products. And the low molecular weight ones, persulfates, metals and salts, organic chemicals, and then relevant compounds uncertain. Here they put wood dust, red cedar. I think we do know that. I'm not sure why that was put under the uncertain relevant compounds, because we do know for Western red cedar that plicatic acid is the key one. And here you can see the polyisocyanates, where the prototype is TDI or toluene diisocyanate. So kind of narrowing this down is sort of a simplified list of this, which is just from a different source. I got this from Up to Date. The other one was from an article about work-related asthma. So here's the panoply of work-related, of low molecular weight compounds and the occupations that are at risk, which are also mentioned here. So you can see the isocyanates, Western red cedar, dyes and bleaches, and this is really more for completeness, so that as you're doing review for the boards or wanting to learn more, you can make reference to this list in Up to Date. And then, as I commented, you can see in the lower left, the high molecular weight compounds are usually organic materials, animal proteins, flours and cereals, certain enzymes and certain occupations that are related, as well as plant proteins. So something that's interesting are some of the mechanisms and features that are important, I think, or interesting to know at least. In terms of the mechanism, and certain genetic susceptibilities. So for certain of these, like for example, polyisocyanates, which are low molecular weight compounds, they've found both IgE and non-IgE mediated mechanisms, as well as some parts of the innate immune response, and certain range of different genetic susceptibilities. And then this is sort of plicatic acid is here, low molecular weight, but there, even despite that, probably because of haptenization with serum proteins that circulate around, can lead to an IgE mediated response. And there's some genetic susceptibilities that are present there. Flower dusts are high molecular weight, IgE, and then there are others that are mentioned here. Interestingly, certain cleaning agents haven't been able to find IgE, but there are some probably non-IgE mediated mechanisms that lead to mast cell activation, and then the kind of the downstream effects of that leading to bronchoconstriction. So I think the key point here is to know that there are some genetic association, particularly with the polyisocyanates, which I don't think you'll be asked to remember all of them, but it's worth knowing that there are some individuals that are at higher risk because of certain HLA subtypes to certain types of occupational asthma. So going back to the case, I'm going to have to speed up here. So it turns out that the Suffolk County Courthouse, they did some weatherproofing in 1993. That's when it started, and it went through a fair time. Poor ventilation. It turns out that they used excess weatherproofing, and there were a lot of people who had symptoms. In our clinic, we had 2 patients, and then in addition to this current patient here, where we noticed that this was the problem. So in the interest of time, I won't go through the thoughts, but these are the materials that were used. Several of them have isocyanates, and then they used some caulking as well, which was 4% methylene bisphenol diisocyanate. So there were some investigations that were done. There was some hedging here, but this was very clearly, there were several people that had isocyanate-induced asthma. And in the interest of time, I'm not going to go through all of this because you can read it, but it is a really a fascinating sort of pathophysiology, because it's a small molecule that causes, for which there is a latency, and has, despite removal, prolonged airway changes physiologically and immunologically that may have to do with the alteration of integrins on lymphocytes that lead to persistence of susceptibility to bronchoconstriction, even in the absence of repeated isocyanate exposure. The treatment is obviously avoidance, and there's no different treatment than there would be for somebody with asthma. So for this gentleman, because he was preparing for the Spartan race, I just, he really didn't have much in the way of other symptoms. I gave him an as-needed short-acting broncho beta agonist, especially before exercise. I considered doing a methacholine challenge to see whether he had persistent airway hyperreactivity, but I decided not to, because it probably wasn't going to really change my my management anyways, but it would have been more out of personal interest. So we've got about 5 minutes left for the 2 review questions. Are there any questions from the group now before we move to those?
Dr. Little, that was a wonderful talk, and we really appreciate it. So I mean, a lot of it is based upon history, but are there any particular things that we can do to confirm that, you know, these are causative of the symptoms, or does that fall into a more difficult realm?
There is some testing. Let me get back to that question after I do the review questions, because that does actually come up. And typically there is testing beyond just spirometry, maybe methacholine challenge if that's indicated, although usually not so commonly. It's a little bit more about sort of timing and sort of patient history. But in some cases, there is testing, and that'll come up in some of the review questions. Okay, let me just move on here. Okay, all right, for some reason. Okay, so I've got two questions for you, and maybe we'll get some audience participation here. So a 45-year-old man started working in artisanal bakery about a year ago and reports about 9 months after starting, of intermittent wheeze and rhinorrhea. He can't really identify a clear trigger, including the relationship to work, as his work schedule is hectic. It's not sort of like 5 days a week, 2 days off. He's been avoiding, for health reasons, cereal-based foods like wheat, rye, etc., just because he was a little overweight and wanted to avoid carbs, basically. So he doesn't recall any prior food allergies. He has a long-standing mild seasonal rhinitis during the summer months, but denies any history of wheeze during his pollen season, so has not really had an asthmatic syndrome. Along with providing a rescue inhaler and antihistamines as you're starting your workup for his intermittent symptoms, and then ordering spirometry. So what is a reasonable initial next step? So one would be provide the patient with EpiPen, as he may have developed a potentially severe immediate type hypersensitivity and allergy to wheat food. Do skin prick tests to seasonal air allergens. Order specific IG testing, whether through prick testing or serum-specific IG testing to wheat, or order serum wheat protein component testing or component resolved diagnostics to characterize the sensation pattern of suspected wheat allergy to refine his possible diagnosis of Baker's asthma. So what do people think here? So is that a vote, Elsa, for the component resolved diagnostics in the chat? Yeah. Okay. Anybody else?
Same.
Okay. So actually, this is an interesting one. I know we like, more expensive is usually better. But the answer here is to order wheat prick testing or serum-specific IG testing to crude, wheat extract. And I'll explain why. So this patient carries a presumptive diagnosis based on history and latency of Baker's asthma, and in the context of there being no prior history here. So of note, these patients typically do not have symptoms of immediate hypersensitivity to ingested wheat of closely related grains, like rye, for example, probably because of difference in the route of sensitization that leads to the asthmatic syndrome, and possibly the major allergens or the allergens that lead to them that are probably heat and acid labile being more prominent. So that's a speculation analogous to food pollen allergy syndrome. So these are people who may have asthmatic symptoms and may have Baker's asthma, as it's called, but actually have no problem eating baked or cooked bread. So skin prick testing to seasonal allergens would be in wheat is a pasture grass, and he has symptoms in the middle of the summer, so other pasture grasses like timothy, rye, etc. And there is cross-reactivity to wheat food and pollen allergens, but this wouldn't really help diagnose his suspected Baker's asthma. It might help him for other reasons and would be reasonable to do, but maybe not the initial step. So interestingly, there was a study done about 8 years ago, that looked at component resolved diagnostics for individuals with Baker's asthma, and they found that the area under the curve in the receiver operating characteristics curve of doing a combination of looking at a host of specific IgE2 major allergens or component resolved diagnostics was actually not as good in terms of Baker's asthma as doing the serum-specific IG or prick testing to crude amalgam of wheat proteins. So interesting there. It might have helped distinguish cross-reactivity to pasture grasses or to wheat pollen itself, which is different than wheat food, but actually was not found to be helpful in this specific situation. And I put a reference there for that. Sorry. Okay, second question here. So a 23-year-old woman with a history of perennial childhood asthma and rhinitis from around age 4, who was on controlled medications in the past with occasional easy visits to the kid. She thought she'd outgrown her asthma, but she now reports a recurrence of symptoms. More background, she grew up in an inner city, large apartment complex where there were recurrent issues with pests, mice, rats at times, cockroach. Fortunately, at age 9, she moved to a new house with her family with improvement in her symptoms in the cold months, but she still had some summer symptoms. By age 18, she needed a rare rescue short-acting beta every 2 to 3 months that was often associated with upper respiratory tract infection. So she graduated from college and took a job as a laboratory technician, performing both bench assays and small animal husbandry, specifically mice and rats, as part of the research that was going on. So soon after starting work, she noticed increased need for rescue short-acting beta agonist use and actually went to an urgent care because these symptoms persisted with wheeze that had not responded to her albuterol. And she was given a brief burst of systemic steroid, which helped her, and then returned to work. But then her symptoms came back and she's referred to you. And on exam, she has some faint wheezes and rhinorrhea. So rather than sort of testing, what is the most likely interpretation of her presentation to be assessed with testing you order? So after a hiatus of her childhood asthma, she has persistence and recurrence of her asthma related to her prior seasonal air allergen sensitizations. She has new onset occupational asthma from chemicals she's exposed to in her bench assays. She has work exacerbated asthma related to childhood sensitization to rodents, or she has new onset occupational asthma related to her work with the small animals. So this one here was great. I agree. So this is a case that would carry a presumptive diagnosis of work exacerbated asthma upon re-exposure to rodent allergens. Although we don't have a workup from when she was a kid, it's highly suggestive that she was sensitized to mouse and rat allergens as a child, moved to a new house where there weren't pests, and her symptoms got better. The year-round symptoms got better, but she still had some seasonal symptoms, probably from seasonal air allergen sensitization. So as you all know, I don't have to tell you this, but just for completeness, while some individuals with childhood asthma destined to have a persistence in adulthood can often have a hiatus in their late teen, early college years, the time course and rapid onset of symptoms after resuming work in this case argue against this being the case. So not the first answer. She could have new onset occupational asthma from chemicals in the lab. These were low molecular weight agents, presumably, and low latency. But the low levels of exposure would have to be reasonably high and are unlikely given our current lab safety protocols. If she had new onset occupational asthma from sensitization to rodent proteins, as these are high molecular weight, you would expect at a latency period, which was not seen as she developed symptoms soon after exposure to the rodent antigens, which if you go into an animal facility, are really quite high, like really significant, because you're walking into a room with hundreds of mice, and there is literature on the non-trivial development of new onset occupational asthma and new sensitization amongst laboratory workers that are doing animal husbandry that is not trivial and probably related to the very, very high levels of antigen that are present in those environments. So I've gone over for 5 minutes, but I'm happy to answer any question, and I'm glad everybody, this one worked out nicely and people were able to differentiate some of the factors in childhood exposure. And this is somebody that could very well be one of our patients. So any questions, anybody?
Well, thank you, Dr. Little. That was a wonderful talk and a great refresher to all of us. As you know, we don't see these cases often, but it's part of our jobs. And for the folks who are taking the boards, those charts are really going to come in handy. So we'll get the video uploaded online so you all can review that when you're ready to go take the boards. Thanks again for joining us. And I know you have a very busy schedule, so.
Oh, it's my pleasure. Yep. And I think we talked about, doing another talk later that might be a little bit more adult related. And do you think the video is enough? You want me to send you the slides, Alan, or what's your preference?
If you don't mind, the slides would be great, and I can distribute them out to the group.
Yeah, because some of those charts, are helpful to look back on, and I kind of brought them together but one by one, it could be like a 5-hour session if we went through each of those syndromes. So great. All right. Well, thanks very much, everybody. It's been a real pleasure.
Thank
And I
you,
appreciate
Fred.
the questions.
Hope your family's doing well.
Yeah, it's good to see you again, Linda. I'll pass on your regards to Claudia.
Yeah.
Okay.
Thank you.
Okay.
Bye-bye.
Bye-bye.
Take care. Bye-bye.